So now it's time for our first keynote speaker of the evening. It's Aseem Malhotra, and I don't know about you guys, but I am totally geeking out. If anyone has ever heard or read anything about health in the last few years, you're bound to have come across his name. And it's really cool, number one, to be able to be in the same room as him, but also to hear him here in Galway without having to travel miles to hear his message. So he's pretty cool. He's been described as an inspiration by Jamie Oliver. He's a consultant cardiologist and is one of the most influential health campaigners in the UK. And he's certainly causing lots of waves and lots of interest with his approach to medicine. And he's also got a new book out, which is really, really interesting and worth a read. So without further ado, I'd like to introduce Aseem Malhotra.
Thank you for that very kind introduction. I don't know if I deserve any of that, but I'm really delighted to be here today, and a special thank you again to Maeve for inviting me and organising this conference. And my background, very briefly, is I'm a consultant cardiologist. I trained as an interventional cardiologist, so that's essentially doing keyhole heart surgery. And I've gone down more the prevention side in the last few years. And hopefully by the end of my talk, you'll realise why that is. My other roles include being a member of the Academy of Medical Royal College's some Choosing Wisely steering group, and you'll get more of an understanding of what that is during the talk. And also I'm a member of the Board of Trustees of the King's Fund, which is an independent health think tank that advises government on health policy. So just to start, my primary duty as a doctor is to do the best for my patients, improve patient outcomes, and practice evidence-based medicine. And David Sackett, who's considered one of the fathers of evidence-based medicine, he mentions three major components to improve patient outcomes. And I think it's important that we start from this basis to kind of remember and understand what evidence-based medicine really means. Individual clinical expertise of that doctor or practitioner, best available clinical evidence, and last but not least, in fact probably the most important, is patient values and expectations. But the reality is, the sad reality is that evidence-based medicine, certainly best available clinical evidence, has been hijacked by vested interests. It's been commercially corrupted. And we are not actually truly taking into consideration patient values and expectations. And before I give evidence for why this is, a bit of humility, David Sackett also said this. He said, half of what you learn in medical school will shown to be either dead wrong or out of date within 5 years of your graduation. The trouble is, nobody can tell you which half. The most important thing to learn is how to learn on your own. And actually, that's what I have been doing, as well as many of my colleagues in the last several years, who are a vocal minority, who are really challenging the conventional, the system that perpetuates poor health, in my view. So what I'm going to discuss in the next half an hour or 40 minutes or so is actually what I have been learning in the last several years. So, sadly, we have a complete healthcare system failure and an epidemic of misinformed doctors and misinformed patients. And these are rooted in biased funding of research. So that's research that's funded because it's likely to be profitable, not beneficial for patients. Biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, commercial conflicts of interest, defensive medicine, and last but not least is medical curricula that actually fail to teach doctors how to understand and comprehend health statistics. So financial conflicts of interest, let's talk about that to start with. So influencing doctors through financial incentives based upon number of investigations and procedures can sometimes put profits before patients. In a minority, greed smothers the conscience. In the United States, one cardiologist was jailed for ordering $19 million worth of unnecessary investigations and procedures. Is that just the tip of the iceberg? Well, in the United States, we know they have a fee-for-service model, which essentially contributes to overuse. So the more procedures you do, the more tests you do, the more surgical operations you do, you get paid for that by volume, not necessarily by quality of care. In the UK, we have something not in the same extreme, but something which is essentially very similar. It's called payment by results, where actually, ultimately, you're rewarded for the amount of activity you do, the amount of health activity you're engaging in. Just to give you one example of overuse. So, as I said at the beginning, I trained as an interventional cardiologist, so I've done thousands of coronary angiograms, which are tests that look at the visualizer heart arteries, and I've done hundreds of angioplasties, stent procedures. And if you're having a heart attack, putting a stent in is a life-saving procedure. To what degree, I'll come on to later. But if you're not having a heart attack, if you've got something called stable angina, and you have a blockage in your arteries, which is diagnosed from an angiogram, putting a stent in, it's very clear, the evidence is very clear on this, it's unequivocal. Putting the stent in does not prevent a heart attack or prolong life. And it's estimated almost 50% of stenting that's done in the United States is questionable, potentially inappropriate, 50%. And this is despite the fact that it's very well accepted that stents don't prevent heart attacks or prolong life. Yet 88% of patients undergoing the procedure thought they were having the procedure for the very purpose of preventing a heart attack and prolonging their life. And perhaps, well, more shockingly, when anonymously asked, 43% of cardiologists said they would still go ahead and do the procedure, even if they knew it wasn't going to benefit the patient. And there are lots of other drivers into this. It's not just the financial incentives. It's, there is a suggestion of maybe there's patient demand, although I think that's less important once they're given the information. The technological imperative, so, the new devices, new technologies come on the market. Doctors, surgeons like to operate. Doctors like to do procedures. So there's an element of that as well, which contributes to overuse. So in 2013, and then 2014, I wrote 2 consecutive editorials. The first one was in the BMJ, and the second one in JAMA Internal Medicine. Now, the first one in the BMJ, I emphasize the fact that actually we've had all this stenting over the years, and about a third of stents done in the UK are done for stable disease, so the indications which are much more questionable. And I'd mentioned the fact, I started off the article by saying the misinformation on this actually probably went all the way up to the President of the United States, or the ex-president at that point. And the story had emerged only a few months earlier that George Bush, the ex-president of the United States, having cycled, it was reported he'd cycled 100 miles a week before, hadn't had any symptoms reported, went for a routine check by his cardiologist and ended up with a stent. And I said it's probably very likely, although we don't know the details, that he didn't have, he wasn't told that this is not going to prolong his life or prevent a heart attack. And I suggested that we should actually be more honest with patients. And the following year, in 2014, I was invited to write an editorial in JAMA Internal Medicine, one of the American journals, in response to a new study relating to interventional cardiology. And I said, well, the elephant in the room is that stents do not prevent heart attacks or prolong life. And actually, what we should do is to protect patients is actually to make it mandatory on the consent form. So actually, when we do angioplasty, we have to tell patients that the procedure carries a risk of 1%, 1 in 100 chance that it can cause a heart attack, stroke or death. But we're not required to tell them it won't improve their prognosis. And, I postulated in my editorial that actually it's important to do this because it will protect patients from unnecessary harm and anxiety. But also, we can discuss lifestyle changes as well. And it shouldn't give them the illusion of protection that they've got a stent in and it means that they're okay and they can take their pills. But there's another aspect to all of this as well, is the fact, as I mentioned, that there's still a potential harm from this procedure. And I've seen patients and assisted in procedures where, 1% chance of heart attack, stroke or death is not small. And I remember one lady that basically had a complication and died on the table. And I thought to myself, if she was given the full information, she may have made a different decision not to undergo the procedure and probably would still be alive today. So really, it's really quite sad that we've got to this level where we are sequestering such important information to patients, and it's clear patients have that expectation or think that they're having the procedure for that reason. So the second article was actually press released, and it was picked up by BBC News. And this was in 2014, and I basically put the case that this is really important, that cardiologists should tell this to patients, and everybody should know this as well, because a lot of doctors, family practitioners weren't aware of this information as well. And a spokesperson for the British Cardiovascular Intervention Society responded to my calls and actually said that there was no evidence in the UK that patients had been treated inappropriately, and also said that changing the consent form was not the best way of ensuring patients understood their treatment, which I thought was very interesting. I had backing from the chair of the Medical Royal College at the time, who's actually now the chair of the General Medical Council, Professor Terence Stevenson, who backed what I was saying and actually said, no, this is an important debate, and actually we feel this is important. Interestingly, what I didn't predict, several months later, JAMA Internal Medicine then actually ended up doing a study where they put this scenario to patients. And what they found was that when patients were told explicitly that the procedure would not improve their lifespan or prevent a heart attack, only 45% then opted for the procedure, whereas when they weren't told, 70% of them opted for it. So there was a 25% absolute reduction, which is quite a lot. And it was extrapolated that if this conversation were to take place in cardiology clinics across the United States, and by the way, it's not difficult. I do this all the time. It takes 30 seconds to explain this to a patient. Just this conversation. From reduction in stenting, it would save US healthcare $864 million a year. This is just from one conversation in one part of our health system regarding stenting. So what about, let's talk about risk and health illiteracy. It's a big problem. So misunderstanding or inability to understand health statistics for the lay public is perhaps not surprising, and doctors often find themselves in positions where they're trying to explain something that a patient or member of the public has misunderstood of something they've heard in the media, and they can't find reliable information, or they misinterpret stuff they read on the internet. Just to give you an example how this can go quite badly wrong, in 1995, the Committee on the Safety of Medicines reported that one of the new contraceptive pills, one of the third-generation contraceptive pills, it was found that it increased risk of thrombosis and by 100%, and it was extensively reported in the media. That sounds quite a lot, doesn't it? 100% increased risk from taking the pill of getting a thrombosis. What did it actually mean? Well, it meant that by not taking the pill, your risk was 1 in 7,000, and the pill increased the risk of 2 in 7,000. So you can see how it's double the risk, but actually, for that individual, the risk of a thrombosis from the pill, in real terms, was only 1 in 7,000 for that individual. And as a result of this pill scare, it was estimated there was 13,000 additional abortions that took place the following year in England and Wales, costing the NHS £4 to £6 million. So what about doctors' understanding of health statistics? Is it a risk factor for misinformation? It's a massive risk factor, in fact. Many doctors actually don't understand how to evaluate the evidence from health statistics, and therefore cannot evaluate the benefit of a treatment. One study showed that in 150 gynecologists, consultant gynecologists, a third of them actually didn't understand the meaning of a 25% risk reduction created by screening for breast cancer, mammography screening. Most of those third believed that if 1,000 women were screened, 250 out of those 1,000 would benefit from not dying from breast cancer. But actually, what did the data tell us? Well, the Cochrane analysis actually showed that you'd have to screen 2,000 women to save one life. 2,000, 1 in 2,000 chance. A few years later, a similar study of 20 gynecologists, none of those people who were asked actually understood the potential harms of screening. So for every one lady that was saved from dying of breast cancer from breast screening, 10 received an overtreatment, an operation they didn't need, or a medication they didn't need. None of them were aware of this. Now, how do we get through this? Well, in my view, it's a very simple solution. If you understand that basics, you have that conversation with the individual patient and make a decision based upon their values and preferences. And that particular female may think, well, that lady may think, well, I've got a very strong family history, I'd go for the screening. Other people will say, well, I don't want to take the chance, I'm okay, I don't want an overtreatment. That's a very simple way of sorting this out. But that doesn't go on in general in consultations, and it should. Okay, so let's just a little bit of a basic statistics test here, okay? Just to get an understanding of a way through all of this misinformation. So there are many ways of actually presenting a benefit. Relative risk or absolute risk. Absolute risk is also synonymous with something called NNT, numbers needed to treat. So if you communicate relative risks as opposed to absolute risks, or the NNT, it can actually lead lay people and doctors to overestimate the benefit of a medical intervention. So let's just give you one example. Based upon published literature, although I must say take this with a pinch of salt because it's a drug industry sponsored published literature, but let's just take this at face value still. If you're a type 2 diabetic and you take a low dose atorvastatin, 10 milligrams, a statin pill, every day for 4 years, the data tells us there is a 48% relative risk reduction that taking a statin for you will in having a stroke. That sounds quite impressive. Patient comes in, doctor says, you take the statin pill, there's a 48% less likely to have a stroke. Okay, so what did the actual trial show? It showed that it reduced the odds of having a stroke from 28 in 1,000, without having the pill, the placebo, to 15 in 1,000. Okay, so 13 out of 28 people, okay, had a benefit. 13 out of 1,000 people, if you look at it. Now, what does that actually mean? That means 1.3% was the actual benefit. So for an individual, for that person, actually a much more transparent and honest way of saying to that patient the benefits of the statin, based upon this industry-sponsored data, is that if you take this atorvastatin pill every day for the next several years, there's a 1 in 77 chance it will prevent you having a stroke. That sounds very different to 48% relative risk reduction, doesn't it? But that's actually the more honest and transparent way of communicating that statistics. Now, mismatch framing in medical journals has also compounded the issue. So if treatment A reduces the risk of developing a disease from 10 to 7 in 1,000, but increases the harm, so the side effects, from 7 to 10 in 1,000, so exactly the same thing, the journal article will report in the results a benefit in relative risk of 30%, but a harm of 0.3% in absolute risk. Isn't that extraordinary? Well, how often did that happen? Well, one sample analysis showed that 1/3 of all medical journal articles published in the Lancet, the BMJ, and JAMA between 2004 and 2006 used mismatch framing. Isn't that extraordinary? So you're presenting data for a drug, exaggerating the benefits and minimizing the harms. And the medical journal is a platform for that misinformation. Now, don't just take my word for it. The man who's considered the world-leading research on health literacy in Berlin, Gerd Gigerenzer, in 2009, you can look this up, it's free online, in a World Health Organization bulletin said, it is an ethical imperative that every doctor and patient understand the difference between absolute and relative risks to protect patients against unnecessary anxiety and manipulation. So I would argue, actually, to not have this conversation with a patient is entirely unethical. But we have been unwittingly practicing unethical medicine for decades. Okay, let me give you a case study. So people like case studies, makes it more interesting. We're going to talk about statins, a little bit more about statins. So a 49-year-old man is seen in outpatients several months after having a primary angioplasty. So he had a stent for a heart attack, okay, which is beneficial. And he comes back to outpatients and he reports very disabling chest pains. And it's not typical of a repeat or recurrent heart pain. It sounds something else. It sounds like it's muscular or there's something else going on because he's got it constantly. So very basic tests are done to make sure there's no acute problem. He's not having a heart attack. That's all fine. And he ends up actually having a repeat angiogram. So I discussed this with my boss at the time, and he says, well, we better make sure there's no new blockage or the stent's not blocked, even though he's not having a heart attack. So we do the angiogram. I'm there in the cath lab, the cardiac catheter lab. I do the angiogram, finish it, 20 minutes or so, reassure him and say, listen, there's no new blockage, your heart's fine, everything's going well. He's reassured, but he's like, doc, what about my chest pain? So as quite often is done in medicine, we think, well, it must be something else. This could be acid reflux from your stomach. So we're going to give you a pill to control acid reflux. Maybe that's giving you the pain. Go and see your family practitioner, go and see your GP. And I will see you in clinic in a few weeks' time. So he goes back to his GP, and then he comes back in 6 weeks, and he sees me in clinic again. And this time his situation's worse. His pain's really bad. He's getting muscle aches as well. And he's depressed. His wife is with him, and she's very upset. And this has been going on for months now. And he is really struggling. And the GP has now referred him to a gastroenterologist for an endoscopy. So he's now about to go and have a telescope test, which is, not the most comfortable thing, to look into his stomach to look for a stomach ulcer, because we don't know why he's got this persistent pain. Nothing's helping him. And I have a chat with my boss, and he says to me, Aseem, well, sometimes, you never know, he's been talking about muscle aches as well as a chest pain. It's a long shot. Maybe it's this statin. Maybe we should stop his statin for a while and see what happens. So I look at his medication list. He's on a very high dose of statin, which is normal for people who have had heart attacks to put them on a high dose statin. And I decide that I'm actually going to stop his statin for a few weeks and say, listen, just give this a go. It may be that you need the endoscopy anyway. And I will see you back here in a few months' time. I couldn't see him any sooner, and obviously his GP could look after him in the meantime. But what I didn't expect is that he turns up, having stopped the statin for 2 weeks, he turns up to clinic uninvited the following week. I get a knock on the door, And he's now elated because his pain has disappeared. But he says to me, he says, "Doctor, thank you. After months of misery, my pain has disappeared, but now I'm worried. My GP says you must never stop your statin or you could die." Okay, now, does anybody here have any idea, can you give me any figures, what you think his risk of death? So he's taking a statin, he's had a heart attack. The benefits suggest people with heart disease benefit from statins, but I will discuss a little bit more about that later. Does anybody know what his risk of death is? Estimate his risk of death from stopping a statin for 2 weeks. Any guesses? None. So that's interesting, actually. Yeah, 0. I mean, maybe you know something I don't. It could be close to 0. It's worse. It's probably anything from 0 to 1 in 10,000. And the reason I say it's close to 0 is if you look at the clinical trials where people take statins and adhere to them, where we get the information, these are people that clearly are not having disabling symptoms because of side effects. If we believe that that these are side effects of statins, a worst case scenario is 1 in 10,000, but it's probably closer to 0. You're absolutely right. So there's been a bit of controversy about statins in the last few years. I've been kind of at the heart of some of that. And I'm going to discuss this very briefly, what actually happened with this controversy in statins. In 2013, in October 2013, 2 articles were published in the BMJ. One was an editorial by me, and the main one was an article by some Harvard researchers which basically reanalyzed the statin data that we have available. So this isn't looking at raw data, it's looking at the published data already, and tried to look at, just exclusively looking at people at low risk of heart disease, would they benefit in terms of taking a statin in terms of death or heart attacks. And what they determined in this piece, which is an excellent article, very informative, is that they found that if you're low risk of heart disease, you have a 10% risk of developing heart disease in the next, or heart attack or stroke in the next 10 years, then taking a statin will not prolong your life by 1 day. There was no mortality benefit, and there was about a 1 in 140 chance that it would prevent a non-fatal heart attack or a non-serious stroke, as in nothing that left with significant disability. And John Abramson and colleagues at Harvard also mentioned something else which is interesting, which is very much related to the conference, is that 80% of cardiovascular disease is actually lifestyle related. For those people, the suggestion was we should concentrate on lifestyle, not give them a pill, which doesn't really improve their lifespan. But what was interesting as well is that he made a reference to a study, a real-world study, which suggested that almost 1 in 5 people taking statins get a significant side effect. Okay? 1 in 5, which is a lot more than what the clinical trials suggest, and this is a real-world study. And those include muscle pain, fatigue, etc., etc. I also wrote a piece in the BMJ which became a big story. It was world news. I was speaking to Fox News, CNN. It was front page of 3 newspapers in the UK, basically saying, as a cardiologist, saturated fat does not cause heart disease. The focus should be on sugar, and actually that got a lot of attention. But I also mentioned we've overprescribed statins to millions of people who are not going to benefit and don't even know it, which is even worse. And I also referenced this issue about side effects, saying probably 1 in 5. The actual figure in the actual study was something like 17.4%, but we rounded up to 1 in 5. And what happened after that, a few months later, is that Professor Sir Rory Collins at Oxford, so this gentleman is considered one of the leading research on statins. He's the director of the Clinical Trials Service Unit in Oxford University, which has commercial agreements with drug companies that sponsor statins, that the raw data on statins cannot be released for independent verification. He actually called on the editor of the BMJ through emails initially, which is public can see now, just saying retract these articles. The side effects is an error. It's not right. The side effects are very rare, basically. And he called for retraction, and the editor said, well, I'm sorry, but we don't just retract like that. And actually invited him to write an editorial critique, which he didn't do. And instead, what happened was either he or the Guardian newspaper then went to him, and it became a front-page story. In March 2014, it became a BBC News story that he had basically said there were errors in this piece that needs to be retracted. And this is what he said. Now, this is crucial to what I'm about to tell you later on. He said there were only 1 or 2 well-documented side effects. Myopathy or muscle weakness occurred in 1 in 10,000 people. And there was a small increased risk of diabetes. Okay, so there was an independent review that went on, and ultimately it was all fine. There was a minor correction to the one reference in the articles, both by John Abramson and myself. And there was an independent panel, international panel, that unanimously concluded 6-0 we were kind of on trial for about 2 months, that there was no case whatsoever for retraction at all. What then happened over the next couple of years, there was lots of things going on in the media and through General Practitioners Committee and the BMA, all came out saying we need access to the raw data. There were lots of concerns about statins. Hasn't been independently verified. And, what ended up happening was NICE actually put out a statement in the middle of all of this saying that we should actually prescribe statins to people at low risk. But not only that, it should be introduced in something called the QOF. In effect, GPs should be financially incentivized to prescribe statins or offer statins to people at low risk of heart disease. There was a backlash by a number of doctors that said, no, we didn't think this was right. There were lots of problems that we felt on the statin data. And ultimately, this was unprecedented. The general practitioners and the grassroots doctors won because NICE basically had to overturn their decision, which is really quite extraordinary. But what then happened more recently, and I think this is just something to put out there because I think this controversy is still going to continue until we get access to the raw data. An investigation by the Sunday Times at the end of last year revealed that Professor Collins, who had actually then done another review of statins, and said that no more than 1% got anything in terms of significant muscle symptoms. He actually, and said millions of more people would benefit from taking statins. It was found that he was co-inventor of a device that was being sold in the United States. Since 2009 it was invented. He had a patent on this device that was licensed by Boston Heart Diagnostics that suggested on their website that 29%, it is known that 29% of people taking statins will suffer muscle pain, weakness or cramps. And the marketing material of this device, where people can basically take a blood test and it tells you whether you're likely to get side effects from statins, also suggested that 58% of patients on statins stopped taking them within a year. This is in real-world data. Most of them saying it's because of side effects, which is extraordinary. And the royalties for this patent was going to the Oxford University department. So what I find very puzzling is a department and head of department that says that side effects are very rare had also invented a device to pick up side effects, and it was being marketed in the States and money was going to his department. I find this very puzzling indeed. Interestingly, Boston Heart Diagnostics actually said they stood by this, and they said that they cited a US task force on statin safety, a several-page document that concluded that the randomized controlled trials, such as those used in the Lancet study led by Professor Collins, had major limitations because patients with statin intolerance were often excluded. Right, okay, a little bit of a broad, big picture view here. I think we try to understand, I'm giving you some sort of little details on individual patients and some controversies, but there are certain things we need to understand, and that is, first and foremost, pharmaceutical companies and medical device companies, they have a fiduciary obligation as businesses to make a profit and declare a shareholder dividend by selling their product. They are not required to sell consumers, patients and doctors, the best treatment. Though most of us would actually like that to be the case. But the real scandals are this, and Peter Wilmshurst, a cardiologist in a talk in Centre of Evidence-Based Medicine in Oxford, says the real scandal is that regulators fail to prevent misconduct by industry, and that doctors, institutions and medical journals that have responsibilities to patients and scientific integrity collude with industry for financial gain. Now, we have an innovation crisis apparently in modern medicine. And it's absolutely true, but there's so much wastage going on that a recent analysis showed that of the 667 new drugs approved by the FDA between 2000 and 2008, only 11% of them were actually found to be truly innovative. 75% of the new drugs were essentially copies of old ones. They just changed the molecules here and there. And the drug companies, it's not surprising when they spend significantly more on marketing than they do on research and development. Some studies suggest 19 times more than actually developing new molecules that are going to actually benefit patients. And we've got to say this on the backdrop of the fact that I'm sure many of you have heard recently the chief medical officer in the UK said there is a big problem with antibiotic resistance. One of the reasons for this, one of the reasons suggested why there's no development of antibiotics, new antibiotics, is because it's not profitable. If you get an infection and you're cured with an antibiotic within a few days, that's not very profitable as suggesting to somebody to beat chronic disease, you want to get as many people as possible taking a drug for the longest time. That's clearly going to be more profitable. So this is another problem why we're not developing better and newer antibiotics. But it's going to cause considerable, it's already causing considerable harm to the population. Now, the former New England Journal of Medicine editor said this: it is no longer possible to trust much of the clinical research that is published or rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. Is she alone? No. Richard Horton, editor of The Lancet, wrote an online editorial last year, and he suggested that, having attended a Chatham House Rules conference with many of the world's leading medical scientists, possibly half of the published literature is untrue. Richard Smith, former editor of the BMJ, he wrote an article in the BMJ referring to a talk he gave where a number of academics were present in the UK, and he asked them, he said, how many of you here are aware in your career of research misconduct, manipulation of data essentially, taking place in your institution through your career? A third to a half put their hand up. How many of you have reported it? All of them put their hand down. And he wrote that something is rotten in the state of British medicine and has been for a long time. Okay, let's just move on to, has overemphasis on medical treatment detracted from lifestyle? Absolutely yes. We have this major crisis globally. In the UK, the figure's now that 60% of adults are overweight or obese, and 1 in 3 children, more disturbingly, by the time they leave primary school, by the age of 11, are in the same category, and the trends are getting worse. One report has suggested that if we do nothing, 90% of the adult population in the UK will be overweight or obese by 2050. Obesity alone is costing the NHS around £6 billion per year. Type 2 diabetes actually is a lot worse in terms of its harm and cost, because actually it's costing the economy, due to lost productivity, and the NHS around £20 billion per year, and failure to act will result in this hitting £40 billion by 2035. And we know that diet now, non-communicable diseases, diet as a major risk factor, has overtaken undernutrition as the most common cause of death worldwide. But obesity is just the tip of the iceberg as well. And I think the first thing to acknowledge is that when we look at the hierarchy of what's actually driving the obesity, it is the obesogenic environment. But for some people, and this is actually true, there's evidence to show in JAMA Internal Medicine that actually people who took statins with the same risk versus people that didn't ended up heavier and more overweight over a period of 10 years. So there is this issue as well, and I've seen this with my patients over the years, that they think that it's an excuse to gorge on junk food, but it's such a medical misinformation mess, because cholesterol and statins are actually very different to diet anyway. The impact of diet has got nothing to do with cholesterol, really. But anyway, so this is another problem, the illusion of protection. But coming back to it, the root cause of the obesity epidemic, we'll talk about flawed dietary advice briefly, but it's really the obesogenic environment. It's become impossible to avoid sugary processed foods everywhere you go, whether it's on the high street, whether it's in gyms, health clubs, at the petrol station. It's become almost impossible to avoid it. But for me, the real scandal, and it's where my journey began, is that we've even allowed our hospitals to become a branding opportunity for the junk food industry. You know, it's got to that point that we have normalized junk food, that even our hospitals are selling and promoting junk food. And this actually is a great branding opportunity, because some hospitals in London, they have 10,000 visitors walking through the corridor every week. You've got a Smith's, which is become a candy store. Most of it, you look at the WH Smiths over there, what you see in the front is sugary drinks, crisps, chocolate bars, and it actually legitimizes the acceptability. And actually, one very interesting study in America showed that pediatric institutions that sold junk food or fast food on site, people who visited those institutions, those pediatric hospitals, were 4 times more likely to purchase junk food when they left the hospital than people that had never been to the hospital in the first place. There's some sort of subconscious subliminal message going on there. Now, there are contracts with hospitals that even deliver junk food to patients who are bedbound. So people have a heart attack. The normal advice is you have to stay bedbound for 24 hours. And I've been on ward rounds where people are being delivered sugary drinks and crisps and chocolate bars. And I remember one patient many years ago, 2012, when he was a diabetic patient, I went on the ward round. He had a heart attack, and he had a full sugared can of Lucozade on his table. And I said, sorry, not Lucozade, Coca-Cola, apologies. And I said to him, Coca-Cola, is that really the best thing you should be drinking? And he goes, well, and he pointed to the Olympic symbols because actually the Olympics, one of the main sponsors was Coca-Cola, and for him, that meant it was fine. There wasn't a problem with it. So this is a problem with, the junk food sponsorship as well of sporting events is really quite extraordinary. And another example, education is ineffective when the food environment is working against you. 50% of NHS employees are now overweight or obese. This applies to clinical and non-clinical staff. So this is a food environment issue, really, that's driving the problem. And it perpetuates a revolving door of healthcare. But we're up against it because the science alone is not sufficient. Science and evidence alone is not sufficient because opposition from vested interests needs to be overcome. So what does the food industry do? What is their kind of marketing PR strategy to kind of, to deflect from blame upon them? They focus on personal responsibility. It's your fault you're overweight or obese, nothing to do with us. That's why most of us are collectively being irresponsible, and that's why we're overweight or obese. Any government action, they say it interferes with personal freedoms. We've got to remember one thing, the greatest public health successes that have happened over the last century, whether it's safe drinking water, seatbelts in cars, smoke-free buildings, happened because of regulation. Not because of cozy voluntary agreements with industries, very industries. And actually, when you look at the increase in life expectancy, since 1900, we're living on average about 30 years longer. 25 of those 30 years have happened because of regulation, not because of personal responsibility and not because of education, because of regulation that protected the public from harm. I'll move on because I know we're a bit short of time, but other things that they do, that anyone who criticizes them or calls them out, and I've been a victim of this, I get trolled all the time, and many of my colleagues who also stand up and talk about this, you get accused of being leaders of the nanny state, you're promoting junk science, you're food fascists, all that kind of stuff. What else do they do? Well, this is an interesting one. It was a bugbear for me for quite some time because for decades people have thought the reason we're obese is because of lack of exercise, and they say it's lack of exercise that's contributing to it. And in 2015, myself and two international sports scientists wrote an editorial which became widely publicized in British Journal of Sports Medicine saying it's actually time to bust the myth of physical inactivity and obesity. And we started off by saying, actually, activity is extremely important for health. There's no doubt about it. It has many benefits in reducing risk of disease. But when it comes to weight, very little at all. And in fact, there are many benefits to exercise, but weight loss is not one of them. And actually, the focus should be diet. And that was really the main crux of the piece. And I think something else we need to realize as well is that it took 50 years from when the first links between smoking and lung cancer were published in the BMJ before any effective regulation was introduced. And it was because the tobacco industry very successfully adopted a corporate playbook of basically planting doubt that cigarettes were harmful, denial, confusing the public, and even buying loyalty of scientists. And I have seen and learnt that the food industry have done the very, very similar thing. The pharma industry in many ways are doing something very similar. So we can learn actually from the history from tobacco. And just to give you an example of the extent of that denialism, in 1994, as late on in 1994, the CEOs of every major tobacco firm went in front of US Congress and swore under oath they did not believe nicotine was addictive or smoking caused lung cancer. And that's the extent of the denialism that they will go to protect their profits. Now, to put things in perspective, in terms of the hierarchy, independent analysis by my good friend and colleague Simon Capel at the University of Liverpool suggests now that poor diet contributes to more disease and death than physical inactivity, smoking, and alcohol combined. So that should be the main focus. And this is something called Tom Friedman's Health Impact Pyramid. Again, just to put it in perspective in terms of the hierarchy, making the default choice, the healthy choice, is going to have much more impact than counselling or education. And we know this from whether it's smoke-free buildings or taxing or cigarettes, for example. The biggest decline in smoking consumption, which had the biggest impact on reducing cardiovascular death in the last few decades, the single biggest factor was the price of cigarettes. That had the single biggest impact. That's why a tax on sugary drinks is going to have the biggest impact on population health. Now, let me talk. Yeah, and congratulations, Ireland are going to be introducing a sugary drinks tax very soon as well, following the footsteps of UK. In fact, Ireland are also, I think, the first country to introduce smoke-free buildings, which was fantastic and had a very rapid impact in reducing heart attacks as well. Now, let me talk a little bit about sugar very briefly. I've been well known for being a campaigner on sugar for the last several years. And I'm just going to give you a brief summary of what I learned and then what led to essentially a huge media campaign on sugar. So the first thing I learned, or one of the few things I learned, is that added sugar, actually the body doesn't require any carbohydrate from added sugar whatsoever. It has no nutritional value, it is not a nutrient, it has no biological value, you do not need it. That's the first thing to understand. And then over the period of a few years leading up to 2013, and we've had a lot of information since then, but this is up to 2013, we'd learned that quite a few observational studies and some randomized controlled trials have specifically linked sugary drinks with weight gain and obesity. And one thing that was forgotten is that when you look at the most common cause of chronic pain and hospital admissions in the UK for young children, it's tooth decay. And the single biggest factor driving that is sugar. It's one of the few things we ingest that directly corrodes teeth enamel. I learned this from a very eminent dentist friend of mine that now passed away, called Aubrey Shaham. And that's, again, really important. This just emphasizes the fact that sugar has absolutely no nutrition whatsoever. There are no essential fats, proteins, minerals. There's nothing of any value, really, from added sugar. And it's certainly energy you don't need. And when we talk about added sugar, we're talking specifically more about fructose. So added sugar or sucrose is 50% glucose, 50% fructose. And high fructose corn syrup, which is used in America and added to a lot of foods, is around 55% fructose, and not much difference. But what we do know from the science is that chronic exposure to fructose or sugar increases liver fat accumulation, which promotes metabolic syndrome or insulin resistance. Now, why is that important? Metabolic syndrome is any 3 of the 5 conditions that include high blood pressure, impaired glucose tolerance or type 2 diabetes, increased triglycerides in the bloodstream, low HDL cholesterol, and increased waist circumference. You have any 3 of those 5, you have metabolic syndrome. And actually, we know now that 2/3 of people admitted with heart attack now fulfill the criteria of having metabolic syndrome. And if you have metabolic syndrome, you're 50% more likely to die or be readmitted within a year compared to people that don't. Interestingly, and I know Sherif will talk about this later in more detail, but 75% of people now admitted with heart attacks have a completely normal cholesterol and LDL. So you can do the math there. Right, very briefly, I think one thing that's important to understand about metabolic syndrome, we keep talking about obesity, and obesity is an issue, but it's a marker of a much bigger problem, because up to 40% of people with a normal body mass index, not overweight, will harbour metabolic abnormalities, the same metabolic abnormalities as people with obesity. So basically, there is no real healthy weight. It doesn't exist. It's nonsense. If anyone says healthy weight, tell them they're talking complete nonsense. There's no such thing as a healthy weight. There's only a healthy person. Now, the fiction. So in terms of this whole epidemic of obesity, beating obesity, Coca-Cola's view is this: it takes action by all of us based upon one simple common sense fact, ladies and gentlemen: all calories count no matter where they come from, including Coca-Cola and everything else with calories. But the science tells us something else, that calories from different sources have different effects on the body. It's actually common sense, is it not? Calories from fiber, protein, fat, and fructose have a different effect on the body. Omega-3 fats, for example, are going to be heart protective. Trans fats are going to increase your risk of a heart attack. So all calories are not the same. David Haslam, chair of the National Obesity Forum, also says it's naive for us to think that they do, because different food will have a completely different effect on our body, and obviously the nutritional value as well is going to be different. So we need to think very differently. It's not about calories, it's where the calories come from. And one really important, very high-quality observational study, which was referenced in the British Journal of Sports Medicine piece, and also the piece I'm about to show you, actually showed that when one looks at the increase in prevalence of type 2 diabetes across the world, this is a Stanford University study, independently done, looking at 175 countries around the world. And what they found was they looked at sugar availability for sale in the population and linked that with consumption, and found that for every excess 150 calories that was available for consumption that came from sugar compared to calories from fat or protein, there was an 11-fold increase in the prevalence of type 2 diabetes in that population that was independent of body mass index and physical activity. So in other words, even if you do regular exercise and you're a normal weight, if you're consuming too much sugar, it's associated, it's likely going to significantly increase your risk of getting type 2 diabetes. So you cannot outrun a high sugar or a bad diet. I think that's a really important message. You cannot outrun a bad diet. And that's what that study showed, which was really quite remarkable data. For many years, we have, and this is actually true in the EU, this still exists, which is extraordinary. I did my own investigation, because once I started looking at the science on sugar, I thought, well, what information are people getting on sugar? And the American Heart Association in 2009 actually published a document saying that the maximum limit for an average male and female in the US of sugar consumption before there was significant associated harms should be no more than 9 teaspoons of sugar a day for a male and 6 for a female. And for the average 4 to 8-year-old child, the USDA suggested no more than 3 teaspoons. Okay? So remember those numbers. Now, a can of Coca-Cola, on the labeling, it gives you something called a GDA, Guideline Daily Amount. So that is supposed to tell you how much you should consume. And you can't see it, it's a bit blurry there, but it tells you, it gives you a figure, and it says sugars in this can of cola, regular can of cola, is 35 grams. Does anyone know roughly how many teaspoons that is? It's actually, so you divide it by 4, so it's almost 9, it's 8.5, so almost 9 teaspoons, okay? So almost 9 teaspoons, but next to it, it says this represents 39% of your guideline daily amount. So that could be easily interpreted, very easily. It's actually suggesting that you should be consuming 22.5 teaspoons of sugar a day. This has been present for well over a decade on the labeling across many products in the EU. It's extraordinary. And we're actually consuming almost that amount. We're consuming, on average, close to that amount. Yet the World Health Organization now has come in, after obviously the public media campaign, suggesting that we should be consuming no more as a maximum limit. So there's a real problem there. People have been misinformed and they're being harmed. You can't argue education and personal responsibility when the public are being misled and misinformed. And when I did further digging, I realized actually what had happened. And I spoke to I won't name this person, but somebody that was involved at the very beginning with the guidelines. The food industry has essentially influenced the guidance. Surprise, surprise. Because what they did was they wanted us to buy products, sugars that were eaten in whole fruit and vegetables should be considered in the same manner as sugar coming from sugary drinks. And they wanted to conflate the two, and really it was just it was a victory of marketing over science and health. And it's really quite scandalous, and it's, in my view, contributed to considerable harm to millions of people across the globe. And I put all of this together in a piece, again in the BMJ. This was earlier on, May 2013, and said that actually we need to change the dietary advice. I called on the Scientific Advisory Committee on Nutrition and people who were influential in the European Union to say we need to change this advice. This is a big problem. It's causing a lot of harm. It was press released by the BMJ, and I ended up going on BBC Breakfast in the good old days when Susanna Reid and Bill Turnbull were still presenting. And it was interesting because I was calling out the food industry, and at the end of the discussion, Bill Turnbull said, we should add that we did ask 10 different companies or organisations associated with carbonated beverages, supermarkets, sugar manufacturers, etc., to discuss this with Dr. Malhotra. All of them were unavailable. I was so disappointed. Okay, we're getting towards the end. A little bit of a quiz. So we talk about numbers needed to treat, putting things in perspective, absolute risk. So as a cardiologist, I care most about heart disease and looking at mortality, death in particular, so reducing risk of death. If you have had a heart attack and then taking aspirin, people know about aspirin, the blood thinner, good drug, they're taking aspirin every day for 5 years. There's a 1 in 100 chance for you as an individual it will save your life or prevent your death, delay your death. Statins are high risk. Again, all of this is industry-sponsored studies slightly, but sadly, but best case scenario, 1 in 83. If you've had a heart attack or established heart disease, it will reduce the risk of, it will prevent, delay your death. Aspirin and statins at low risk, well, you know the answer to that already. If you are not had a heart attack, you're not high risk, infinity. You're not going to live one day longer. There is no number needed to treat. It's infinity. And what's interesting is, when it comes to statins, 75% of people across the globe are actually taking statins in the low risk category. And there's over 100 million people taking statins. Now, I'm not against statins, but against lack of transparency in their prescription. So people should be given that information and then make a choice. Coronary stents during a heart attack. So I said it was a life-saving procedure. 1 in 40 chance, with everything else that's being done, that the stent itself, if you have an acute blockage and you're having a heart attack, it will save your life. Coronary stents at any other time, well, you know the answer, infinity. It's not going to prolong your life or prevent a heart attack. So what's the most powerful, according to the published data that's there, randomized controlled trial data, what's the most powerful coronary intervention tool we have? Does anyone know the answer? It's the Mediterranean diet. Secondary prevention trial, it was an independent study, Lyon Heart study, and mortality was 30. It was quite extraordinary. For heart attack, recurrent heart attack was also very small, and even reduction in cancer, which they saw, which was pretty extraordinary, about 1 in 30 as well. They couldn't explain why that was. Just over 4 years in heart attack patients following a traditional Mediterranean diet, by the way, versus an American Heart Association low-fat diet, which by conventional standards, today's standards, is still quite a healthy diet. So you could argue that if you compare this diet with the average Western diet, the benefit benefits probably would be even stronger. But this information is extremely powerful, but we've held it back, we've sequestered it from patients and doctors as well in terms of the way they communicate with patients. And what we need is actually greater transparency. These conversations need to be had when everyone in the room knows that a stent isn't going to prolong your life for stable disease, but a Mediterranean diet is the most powerful, effective tool we have. When the doctor, the nurse, the receptionist, the cleaner, the patient, everybody in the room knows, that's when you get real transparency, you get better accountability, and that's when you have real quality care. And that fits in with what David Sackett, his rules, his idea of evidence-based medicine, that's what it should be. And we're not practicing that, but we have the information, we have the solutions to sort this out. Okay, so a little bit about Pioppi. So I, in my own kind of journey in the last few years, had the privilege of making a documentary film with my co-author who's standing there on the far left, Donal O'Neill, who's a former Northern Irish international athlete and documentary filmmaker. And we went to this tiny Italian village in southern Italy called Pioppi, which is an extraordinary place. But the reason we went there was that Ansel Keys, the American scientist that first sanctified and said that saturated fat was linked to heart disease and cholesterol, one of the most influential men in the history of medicine and nutrition, if you like, responsible for changing dietary guidelines, promoting low fat in the late 70s in the USA and 1983 in the UK. He spent 6 months of the year for 30 years living in this tiny Italian village and conducted a lot of his research from there. And what's extraordinary about this village is when you go there, and it's still very, they've maintained a lot of their tradition, they have a very high life expectancy. So average life expectancy is close to 89 for men and women, almost 10 years more than the average Tour de France cyclist. And they do no prescribed exercise. There's no gyms in this place. They just walk everywhere. They're always moving. So we went there to try and discover what were the secrets about this village and how do we marry the secrets of this village with what we know of the up-to-date scientific evidence. And we wrote a film which premiered in the British Parliament last year called The Big Fat Fix. You can download it online. It was screened in the European Parliament. And the book we wrote is actually based on the film, and it goes into the science but also gives people a kind of plan, if you like. But one of the things is we wanted to also redefine diets. Diet comes from the original Greek word dieta, which means lifestyle. And actually, it's about a lifestyle. So some of the myths that are busted, really, is that the Mediterranean diet has actually been wrongly interpreted for a long time. Providing you cut the carbs and sugar, eating fat does not make you fat. It's about as likely to make you fat as eating green vegetables is to turn you green. So very unlikely. Does not clog the arteries. Cholesterol is actually good for you if you're over 60. Sharif will talk about that. Actually, it can protect you from an early death. Physical activity and obesity is also a myth. And actually, as being last but not least, dietary changes and lifestyle changes are more powerful than any drug in the prevention and treatment of type 2 diabetes and heart disease, and the benefits are very quick and they come without side effects. So I've written this book, and in the break, there is a stall here, so I'll be happy to do a book signing at about 7:30 if people are interested in buying the book. I'll be very happy to do that. And I'll just finish with one final slide. The pioneering heart transplant surgeon Christian Barnard, perhaps, I think regretfully at the end of his life, said, "I've saved the lives of 150 people with heart transplantations. If I'd focused on preventative medicine earlier, I would have saved 150 million. It turns out lifestyle is that medicine." Thank you very much.
Wow, I don't really know what to say to that. Brilliant talk, and as a health journalist, so many great facts, which is what's really important nowadays, because certainly when you're talking a lot about these subject areas, there's an awful lot of people who come out to try and dispute what you're saying if it's any way different from the line being taken officially. So it's actually great to have so many facts available to us all from that talk.